Details of the patient. Here is a patient by name XYZ, aged 37 years, male patient, hailing from Shaniwar Sante of Hassan, educated, bachelor degree, BA, and occupation currently unemployed. Informant is patient's brother and is reliable and is right-handed. Admitted on 12th of this month 2023 and examined on the same day. Coming to the chief complaints, patient complains of involuntary movement involving all four limbs since 10 years, and he is also complaining of difficulty in walking since 8 years, and complains of memory disturbances since 1 year. Coming to the history of the presenting illness, patient was apparently normal 10 years back. When he was pursuing his degree, he was able to do all his daily activities by himself with good scholastic performance. He used to go to school by walking and was also involved in running and sports activities. He then noticed abnormal involuntary movements involving his hands and fingers bilaterally, which are of gradual onset. Later, it progressed to involve bilateral foot. Later, in the course of 3 years, has progressed to involve all four limbs, head, neck, trunk also. And the movements are constant. They are present both during the rest and during the movements. They are not altered by particular position and not affected by environment, temperature, or emotion. And the movements disappear on sleep. Shall I proceed, ma'am?
Yes, yes.
However, there is no history of, suggestive of weakness of the limbs. Patient can hold the objects, can mix the food and tries to eat, can also hold the comb and tries to comb. But because of the involuntary movements, finds it difficult to carry out the act. 2 years later, patient developed difficulty in walking because of the involuntary movements involving the lower limb also. There is difficulty in wearing the slippers and to grip the slippers because of the involuntary movements. However, there was no difficulty in clearing the ground and there was no stiffness in the lower limbs, no history of foot hanging freely when the patient lifts his foot to put a step. Patient also had recurrent falls and sustained injuries while walking and while carrying out the activities. In the course of the disease, there is also involvement of the head, neck, and trunk also. Since 2 years, patient attenders has noticed there is change in behavior of the patient in the form of difficulty in understanding the things. When some command or action is told, patient fails to do it and repeatedly they have to tell for him to understand. And also there is increased forgetfulness in the form of recent memory and memory also. However, the patient can remember the past occasions. Also, there is low mood and patient tries to restrict himself to home. There is also a history of slurring of the speech which is present. Coming to the negative history, there is no history of swaying while walking. There is no history of stiffening of the limbs or thinning of the limbs. There is no history of fasciculations. No history of neck pain or back pain. No history suggestive of involvement of the sensory or the autonomic system. There is no history of ptosis or double vision or decreased vision. There is no history of bowel or bladder involvement. No history of dysphagia, dysarthria or nasal regurgitation. There is also no history of dyspnea, orthopnea, palpitations, chest pain. There is no history of hard of hearing and also no history of weight loss, loss of appetite and toxin exposure. Shall I proceed now to the past history?
Yes. No, we will discuss. After that, we will go to past history.
Yes, ma'am.
We will discuss that movement disorder. No?
Yes, ma'am.
So it's a very long duration.
Yes, ma'am.
Involuntary movement. So what we are getting from your history is long duration, 10 years.
Yes, ma'am. Chronic onset.
Second is symmetrical, apparently symmetrical. Third is distal and progress. These are the key points. So we'll try to analyze each one of them. You said that there are involuntary movements, no?
Yes, ma'am.
Would you like to elaborate? And you see, you have got, we categorize the involuntary movements into hypokinetic, hyperkinetic, if they are organic.
Yes, ma'am.
So the hyperkinetic movement covers a group of disorders. Hypokinetic movement disorders cover a group of disorders.
Yes, ma'am.
This you believe is hyper or hypo?
According to the patient history, it looks like hyperkinetic.
Very good. It's a hyperkinetic movement disorder.
Yes,
Under
ma'am.
hypokinetic movement disorder, what are all the conditions which are coming?
Under hypokinetic, it is the mainly Parkinson's disease, ma'am.
Yes, bradykinesia,
Bradykinesia.
rigidity, athetosis,
Yes.
dystonia. So bradykinesia, rigidity, athetosis, and dystonia are the movements which are classified as hypokinetic.
Yes,
Under
ma'am.
hyperkinetic, we have got chorea, myoclonus, tremor, hemipallismus. So they are all coming under hyperkinetic. No?
Yes, ma'am.
At this point of time, I would like to ask you to tell what all the features which will suggest a non-organic movement disorder. That is for our learning purpose only I am asking.
Non-organic means functional, ma'am.
Yes.
Yeah, functional, actually the movements, they'll be present only in presence of some attenders, like when there is attention.
Yes.
And the movements will be altered by emotions.
Will organic movements be altered by emotions? I'm sure you might have seen Parkinson patients.
Yes,
they will tell, no, I am otherwise all right in the early stage. But when I am trying to take a class or when I am trying to address a gathering, my movements become worse. So I have now stopped attending gatherings. So will emotions aggravate organic movements?
They may.
They will.
They will.
Because you have got so many dopaminergic system.
Yes,
one is the tubero-infundibular. Second is the mesolimbic. Third is the striatonigral. The three vital dopaminergic system is tubero-infundibular, that is endocrine system.
Okay, ma'am.
Hypothalamo-pituitary adrenal axis is maintained by the tubero-infundibular dopaminergic system, so that doesn't come under the movement disorder. Okay. Other two are mesolimbic. Mesolimbic is limbic system. It connects the limbic system, emotion. Yes, striatonigral is a movement disorder. So movement and emotions influence movement because of the mesolimbic dopaminergic system and the striatonigral dopaminergic system. They function in a modulatory fashion. Previously, sometime I think I have told about something about anatomy of movement disorder. Everything is modulation. So I am sure all of us know that when we are emotional, we show a lot of movements.
Yes, ma'am.
But those movements are within the socially acceptable limit because there is a balance between mesolimbic and striatonigral system. When there is one system failing and other system remaining all right, like for example, movement disorders where the striatonigral may be at defect and mesolimbic may be normal. So the modulatory influence of the mesolimbic on the striatonigral will be not proportionate. Your striatonigral is already sick. So it will produce disproportionate movements because of the push-pull mechanism failing. Two people are pulling a rope from two sides, each are equally balanced, means the rope will stand. Supposing one group is weak, the other group will take over. So like that, when there is an abnormal movement, mesolimbic is preserved in those situations. So all emotions aggravate organic abnormal movements. So that point doesn't help you. As you said, one presence of others. Second, occurring in sleep. If it is there, it is always organic. Third, bizarre movements, uncharacterized movements. We know that we have got hyperkinetic, we have got hypokinetic, and under that so many movements are there, and there is an overlap of these described movements. But you get uncharacterized, bizarre movements. We tell about fencing, the pelvic thrust.
Yes, ma'am.
Pelvic thrust, opistotonic posturing, rotary movements of the trunk, and which cannot be characterized into an organic movement. And it is not stereotype. You see, if you take a video of that movement last week and take another movement this week, even though patient may show the same rotary movements and the pelvic thrust and other things, it will not be superimposable because it is very difficult to imitate exactly. Whereas when the movement disorder is organic, it is superimposable. So check 2 months, they will be alike. Whereas psychogenic, even though they try to emulate the same semiology, it will not be exactly superimposable. Fourth point is there is a phenomena called entrainment. You supposing the person has got a distal involuntary movement, you try to hold that distal part, the movement will migrate to the proximal part. That doesn't happen in organic disease. Okay. So when you suppress one point, patient will try to shift the movement to another point. That is called entrainment. This is also a feature of psychogenic movement disorder. And next point is when you distract.
Yes, ma'am.
Normally, when there is a dual tasking, like you tell a patient with a movement disorder to do a mathematics. So when you are walking, please do 100 minus 7. Then the movement will worsen. That is called a dual tasking. When the person is unable to do the movement normally with the when he simply focused on the movement alone, when you give another task, the movement will become very worse. Whereas in psychogenic, when you give a dual task, he will shift his concentration to the mathematics and forget about imitating the movement. So during dual tasking, psychogenic movement disorders become suppressed, whereas organic movement disorder becomes amplified. So these are some of the points which will help us to know many movement disorders are psychogenic. So that also we should know. So now we know that your patient has got probably a hyperkinetic movement disorder. Yes, under hyperkinetic, I would have told in some classes, when you are describing, always try to describe as far as possible the rate, range, rhythm, direction, amplitude, any specific relieving factor, any specific precipitating factor, or any unique features. So these are the titles under which we discuss. So these are rate, we think it is hyperkinetics. That's a fast movement.
It's hyperkinetic.
Range. Apparently, it is distal. So range is the area that is covered. Is it rhythmic or not? If the patient is able to tell, you can tell. Otherwise, you can say that from the history, I cannot say rhythmic or not. I will have to examine. Because if you are getting a rhythmic movement, it automatically falls into the tremors.
Tremors, yes, ma'am.
So is it rate, range, rhythm, direction? Whether it is horizontal, to and fro, multi-directional, rotary. So all this will help us to design above, up and down is tremor. Horizontal action tremors, definitely red nucleus. So like that, the direction also helps us. Multi-directional may be dyskinesias and choreas. No?
Yes, ma'am.
So that way, rate, range, rhythm, direction. Amplitude. Is it fine amplitude or large amplitude? Very fine movements may be physiological movements like anxiety, tremor of anxiety, yes, or drug-induced tremors. You take a beta agonist for asthma or something like that, and then you get a tremor, or mild thyrotoxicosis. So these conditions, you get a very fine tremor.
Yes, ma'am.
So that is a low amplitude, whereas high amplitude tremors are always whatever movement. High amplitude movements are pathological. So rate, range, rhythm, direction, amplitude. In our case, it is distal.
It is distal, non-rhythmic.
Yes, non-rhythmic.
Multi-directional.
Multi-directional.
Large amplitude.
Large amplitude. Is it repetitive?
It is not repetitive, ma'am.
Not repetitive. And is there any precipitating factor? Any specific like emotion, or taking coffee, taking alcohol, or sleep, or anything that is precipitating or relieving is there?
It disappears on sleep, ma'am.
Disappears on sleep. Yes, any precipitating factor does he tell?
No, ma'am. No precipitating factors, according to history.
Okay. Then any unique features? Like we say that just antagonistic. A unique feature means you have an involuntary movement which disappears with alcohol, means you know that group of tremors, familial tremors. Or if you have a just antagonistic, you touch at one point, the movement disappears. That favors some kind of dyskinesias. No? So yes, like that, any unique feature is there or not? So
no, ma'am. In this patient, it is not there, ma'am.
And third important point is, it is upper limb onset. Upper in limb onset, and later upper limb onset and later went on to the
lower limb.
lower limb. Generally, young people, some majority of the movement disorders start with the lower limb in young people. In older people can start in the upper limb. There are some movements which start in the upper limb. So these are giving lot of clues for us.
Yes,
so at the end, we have got a patient who is having a chronic, progressive, organic, distal, non-repetitive, fast, multi-directional movement which disappears during sleep.
Yes, ma'am.
So among these tremors, very less likely it is not rhythmic. Can it be myoclonus? No, it is shock-like. Can it be balismus? It is distal and proximal violent singing. So it is not fitting into any one of them. So it fits typically into chorea.
Yes.
So how are you going to describe chorea?
Chorea is involuntary, quasi-purposive, non-rhythmic, non-patterned, involving crossing large joints, high amplitude.
So quasi-purposive, non-repetitive, jerky, distal more than proximal, and which is present during wakeful hours and absent during sleep. That is chorea. Chorea is defined as quasi-purposive, non-repetitive, sudden, jerky, distal dominant movement disorders which disappears during sleep. So it is chorea. So chorea can be due to various causes. Acquired causes. Can you tell some acquired causes?
Yes, ma'am. We can divide acquired causes into vascular. Vascular causes will be usually sudden onset and involving the caudate nucleus. Then it can be infective causes. Infective causes includes HIV most commonly, then toxoplasmosis and prion disease. Then it can be toxin induced or drug induced, where because of the drugs like levodopa, amphetamine, and the anticholinergics and anticonvulsants. Then it can be autoimmune also. In autoimmune, it is APLA, SLE, and autoimmune Sydenham's chorea.
So common causes for chorea, if you want to tell, we'll first and foremost, whatever may be the age, we will tell rheumatic chorea.
Yes, ma'am.
Second, as you said, you can tell about SLE if the person is a female. The male's SLE is very uncommon. Then you can tell about autoimmune encephalopathies.
Yes, ma'am.
Then you got the
metabolic
like diphenyl hydantoin, commonly used, or long-term use of antipsychotics. They can do that, diphenyl antipsychotic. Otherwise, this toxoplasma, HIV, all those conditions, it is really not a typical chorea. It involves the basal ganglia, toxo involves basal ganglia, but it is usually a rigidity and dystonias rather than and encephalopathy rather than chorea. Chorea I have not seen in any toxoplasma. It is very, very less likely. Then you have got polycythemia, conditions like polycythemia, the hypoxia due to any cause. So these are some acquired causes. And you have got a long list of inherited causes.
Acquired causes, it's metabolic derangements also. Like most hyperglycemia. Yes, ma'am.
Agreed.
Yes, ma'am.
So when do you suspect an acquired cause? What are all the situations where you suspect an acquired cause? One thing, when it is hyperacute in onset.
Yes, ma'am.
It has got a short period of progression and then plateaus down. When if it is unilateral. So if it is unilateral, sudden onset, short period and plateauing down, then you may think it is acquired cause. When it is bilateral, symmetrical, subacute, chronic, progressive, then you think of a degenerative. So in this patient, it is not fitting into an acquired cause. Obviously, from whatever history we have got, it doesn't look like an acquired cause. It looks like an inherited cause.
Yes, ma'am.
So it is upper limb dominant, coming down, symmetrical. So under the inherited causes, if you want to think about the cause of chorea acanthocytosis, young person.
Neuroacanthocytosis.
You should not forget chorea acanthocytosis.
Yes, ma'am.
Where the typical feature is chorea involving the perioral muscles. So they will have self-mutilation.
Yes, ma'am. Self-mutilation.
They bite their lips and other things.
Yes,
then you have got Huntington's Chorea,
Yes, ma'am.
neurodegeneration with brain iron accumulation, Wilson's disease,
Yes, ma'am.
hyperparathyroidism, or Burns and Farr syndrome where there is basal ganglia calcification. So these are some of the Huntington's and Huntington's-like disease.
Disease like, yes, ma'am.
Yes, you have got. So these are coming under degeneration. And rare causes of chorea will be like Whipple's disease, which is not that common in our country, but once in a way, if you see, we will not be surprised. So this looks like a degenerative chorea, and the chorea is happening in a young person. So the most important differential diagnosis, is it neuroacanthocytosis? Is it Huntington's? Or is it Huntington's-like disease? Then, of course, you have got a metabolic disease which can have a variable presentation, like what is that? Whether you will have severe self-mutilation. I will get that it is and chorea and behavioral disorders. That I'll get the name in some time. I'll tell you. Correct. Leishman syndrome.
Leishman disease. Yes, ma'am.
So that is one thing which can produce bilateral symmetrical chorea.
Yes,
and that also you have to remember. Very good. So now, this is the description of the upper limb. Then in the lower limb, what kind of movement you are getting? You said walking difficulty. Is the involuntary movement same?
Yes, ma'am. Same movements.
Is the walking difficulty due to the involuntary movement or any other component is operating?
No, ma'am. According to the history, like the walking difficulty is mainly because of the involuntary movements. There is no history of swaying. Like we can.
So we want to know whether there is any additional feature. So we will try to describe, even though the patient has got a similar involuntary movement, it's okay. We will try to find out what about the anti-gravity stretch. If the patient says that I have difficulty in clearing my feet from the floor, then you know some apraxic element is there, so some degenerative disease which is involving much more than the caudate nucleus. It may be involving more than the caudate nucleus. So whether there is an additional gait initiation defect. Is there any additional Parkinsonian features? We call start hesitations or apraxias.
Yes, ma'am.
Next, you can ask, so anti-gravity stretches, stepping, propulsion, equilibrium, like that we tell. So we want to know whether the gait is purely involuntary movement or anything else. So anti-gravity stretch, is it all right? What about the stepping? When one foot goes up, the opposite foot should come down. That is called stepping. So if there is a lack of stepping and results in dragging, so patient is unable to lift one leg and put the other leg on the floor and alternatively do that, means he is dragging. That might indicate a pyramidal tract involvement. Otherwise, during the phase of stepping, is the leg getting pulled in another direction? Hung up leg. When an involuntary movement superimposes, he is not really dragging, but the leg becomes pulled in another direction. That can be involuntary movement, or the leg becomes twisted, or is it trembling, is it jerking? All those things you can ask. So twisting, turning, trembling, these are the various involuntary movements which can get contaminating a stepping phase. Or is it the stepping phase itself affected? If the stepping phase itself is affected by unable to do double step, it is a pyramidal disease. Or if the patient is saying that when I am lifting, there is twisting, there is turning, there is jerking, that means it is involuntary movement. So that is anti-gravity stretch. Next is stepping. Then you come to equilibrium. So during, anti-gravity stretch is all right, stepping is all right. When I am trying to move forward, I am swaying to either side. Then it becomes equilibrium. Cerebellum or vestibular system and its connection. Next comes the propulsion. So if all this is all right, you probably think that there is no rigidity, there is no involuntary movement operating, there is no spasticity. Now let me see what is happening in the propulsion. During propulsion, we will tell stance, what is the distance covered between 2 feet during stable standing.
Yes, ma'am.
Pace is the distance covered between 2 feet during stable walking. So stance, pace, turns. And then is it the heel first gait or the toe first gait?
Okay.
Does he have a stamping? Does he have involuntary movement which is getting superimposed during that phase. So stance, pace, turns, movements. Then what about semiology? Is it heel first or toe first?
Okay.
And then can he climb up? Can he climb down? Can he stand on one leg? So all this will complete the complete description of the gait which we can ask. Then we will know whether there's an additional element of extrapyramidal involvement. All these involuntary movements are classified by Stanley Fon into peer movements, which are unadulterated chorea or dystonia or something like that, or movement disorder plus whether there is spasticity, whether there is rigidity, whether there is dementia. So that becomes a plus. So that puts the disease into one category: autonomic involvement, joint involvement, systemic involvement, encephalopathies. All this will give us a diagnostic clue. So is it a peer movement or movement plus some other part of the axis? So from whatever history we have got, it apparently appears that so far there is no spasticity or rigidity. Yes, and the gait appears to be related to the involuntary movement only. So that we will conclude after giving some information that my patient's anti-gravity stretch is all right. He is not dragging and he is not having any kind of swaying or reeling. But when he starts moving, halfway through the movement, the involuntary movement superimposes. Because of that, his gait becomes bizarre. So that is all. So it looks like a chorea which started symmetrically in the upper limb and came to the lower limb. You did not have any oculomasticatory choreic movement resulting in self-mutilation or tongue injury.
Yes, ma'am.
Suppose so. And then he developed memory problem, I think. No?
Yes, ma'am. In recent 2 years, the patient has developed memory problem and also difficulty in understanding, ma'am. And also there is low mood and the patient restricts himself to home, ma'am.
So we'll go one by one.
Yes,
change in the understanding some of the commands that or actions that is called. So does he have a comprehension problem or does he take little more time to react?
He'll take
one thing what you are talking, he is not understanding. That can be a language problem.
But after telling repeatedly, he'll understand.
So that does what does that mean? He is taking more time.
Yes, ma'am.
So if you repeatedly tell it, does he give the correct answer?
Yes, ma'am, he'll give.
So what is the term called?
Cognitive
impairment. If you don't understand due to a language problem, for example, an aphasic patient.
Yes, ma'am.
You repeat 10 times also, you will not understand. Unless the patient starts recovering after 1 month, then he will start understanding. Because there it is the Wernicke's area, which is important for comprehension, that is damaged.
Yes, ma'am.
So then you put it is a focal disease. Whatever disease which is going on is seeming to be generalized, symmetrical, distal. On that, is there a focal disease getting superadded? If you say that, he is not able to comprehend spoken words consistently. So like what you told now, you should elaborate that history. My patient is not quickly responding like before. For him, a question has to be asked many times. And when the question is asked many times, he gives the correct answer. So that in neurology, we call it as slow and right. Otherwise called mental slowing.
Okay, ma'am.
That means mental processing time is increased. That is mental slowing. Supposing you have got a cortical disease, which involves the Wernicke's area or Broca's area or the whole of hemispheric degenerative disorders, then they are quick and wrong. It is not the processing time that is affected. It is the understanding of the concepts itself is wrong. And they themselves don't know that they don't know. So you ask, what did you have for breakfast? He will simply tell dosha. He would have taken idli.
Yes, ma'am.
It will be like a confabulatory answer in a cortical disease. So that is called quick and wrong. Whereas subcortical disease, it is a slow processing. So they are slow and right. So your patient is suffering from mental slowing. It is slow and right.
Yes, ma'am.
So that indicates a subcortical type of cognitive impairment. Cortical cognitive impairment is quick and wrong. Subcortical cognitive impairment is slow and right. So
Yes,
for this, we have got a test in neuropsychology. You can test, that is called digit symbol substitution test. There are some digits and some symbols. Supposing 7. For 7, you put X. And for 10, you put Y. Something like that. Each digit has got a representative symbol.
Yes, ma'am.
That will be on top of the neuropsychology evaluation sheet. And down, so many random numbers will be given. Then you tell the patient, sir, look at the corresponding symbol there, and under each digit put a symbol. That is called digit symbol substitution test. It is a timed test based on the educational status. For a person who has never gone to school, the time can be more. Based on the school years, there are standard timings. So these are time tests. Digit symbol substitution test. If the time consumed is more, but is correct, it is mental slowing. Or if he is simply putting some symbol he likes under any number, it is a cortical dementia.
Yes, ma'am.
So that is the digit symbol substitution test. Similarly, for motor slowing, we have got the finger tapping test. You have got a equipment where you can tell the patient to tap with the fingers, how many taps he makes per minute. That is for motor slowing.
Okay.
So this is mental slowing. Looks like because he is slow and correct. So you should take more questions and tell, instead of telling he is not understanding, then you are going to put the lesion in the language area. Then we will shift from a degenerative condition to an acute condition. As he told, one of the points, focal onset. Focal onset is a feature in favor of acute conditions like vasculitis or tumors or demyelination, whereas inherited ones are symmetrical. Or on a symmetrical disease, if there is a focal thing coming, it may be dual pathology. Patient with chorea going into some other infarct. He may be smoker and he may be developing an infarct. So like that. So this comprehension defect is not really comprehension defect. He takes more time. Questions have to be repeated and he gives right answer slowly. It's a mental slowing. It's not a comprehension problem. And he has got a recent memory and immediate memory impairment. So what are all the points in favor of those things? This is not history, no? In the history, you should tell.
Like if some things are told the minutes or hours back, he will forget, ma'am.
Which one, ma'am?
If some things are told to him some hours or minutes back, he will forget that, ma'am. But he can remember the past occasions.
Okay. So what does that mean? So suppose he has been told, sir, give this letter to your son when he comes. And the son comes 2 hours later, he will totally forget.
Yes, ma'am. And when they ask what breakfast he has done in the morning, that he can't tell, ma'am. He'll forget that.
Okay. So what does recent memory impairment indicate? So definitely forgetting information conveyed to him recently, he is forgetting. That is evidence. Food forgotten, those things will keep it there. Any information conveyed is failed to convey, or you have given him an answer, where has my children gone? Your children have gone to school. Then after 10 minutes comes and asks, where have my children gone? He asks. That means definitely recent memory is impaired. Recent memory is in which part? Both hippocampus, medial temporal region. Or you can put it in the Papa circuit. Medial temporal region or the Papa circuit is involved. So apart from the caudate nucleus, which seems to be involved bilaterally and symmetrically, now we are getting involvement of the limbic structures, other limbic structures, that is hippocampus or the Papa circuit is getting involved as evidenced by recent memory impairment. Remote memory is retained, you told. What does that indicate? This is definitely an organic memory problem. All organic memory problems, recent memory will be lost, remote memory will be impaired. But there are only few conditions where recent and remote memory is impaired in organic disease. One is neurosyphilis.
Okay, ma'am.
Second is HIV. Third one can be even Huntington's disease. Sometimes reason and remote can be impaired because of global brain dysfunction. So neurosyphilis, HIV, and Huntington's disease. Sometimes reason and remote memory is involved. Otherwise, typical feature of pseudo dementia is everything is forgotten. Recent is forgotten, past is forgotten. You ask anything, I don't know answer. So patient says, I don't know for everything. He does not know where he studied. He does not know what he ate. So recent and remote impaired, I don't know answers. And patient will complain, not the relatives.
Yes, ma'am.
Patient goes on asserting that he has got memory impairment. Cancer phenomena, that is, he gives near normal answer. To convince the examiner that he is really affected, you ask what is 4 plus 4, he will say 7. Because he finds it difficult to search and give a wrong, terribly wrong answer. So 4 plus 4 is 7 or 9, they are called near normal answers. It is called cancer effect. So a patient is complaining, there may be emotional element, patient may appear very depressed, recent and remote is impaired, and cancer effect is there. And then you find that there is fluctuations, at sometimes is very much normal, and in functions which need intellectual capacity, like writing a project he may do, but routine things he might forget.
Yes, ma'am.
Then of course you have got evidence in other neurological signs will not be there, and you do the investigations, EEG, MRI, evoked responses, functional imaging, everything will be normal where they can be abnormal in pseudo-dementia. So pseudo-dementia will affect remote and recent together. With some exceptions, organic dementia generally involves only recent memory. So this looks like an organic memory impairment clubbed with the mental flowing. Then patient can remember past. Also there is low mood. Low,
Yes.
what do you
According
mean
to
by
patient attenders, ma'am.
what do you mean by mood? What do you mean by affect? We have got sometimes affect and mood.
Patient is not involved in any activities.
So that is the definition of mood. Supposing you are not involved in any activity, you don't call it as mood. No? So mood is the prevailing ongoing emotional status. That is mood. Mood remains for hours or days. Whereas affect is the expressed emotion.
Yes,
You may have a low mood. You may express the low mood. You may say, I am wanting to commit suicide. I don't want to eat. I don't want to sleep. That is the affect. Affect is the expressed component of emotion. Whereas mood is the prevailing emotional state. Mood remains over a longer period of time, and affect is for brief periods of time. So the importance is the low mood can be purely psychiatric, or it can be a dysexecutive function due to frontal lobe involvement.
Okay, ma'am.
So if it is due to reaction to the disease, psychiatric condition, there will be a lot of affect apart from the apparent mood. A person with a reactive depression resulting in an altered mood will have both the mood component and the affective component. So he will entertain not wanting to eat, not wanting to sleep, wanting to commit suicide, express your worthlessness and uselessness. That means it is a reaction to his disability at this young age.
Yes, ma'am.
Supposing it is a dysexecutive function, they generally do not have any of these symptoms of wanting to commit suicide, worthlessness, and they simply remain low and they do not set a goal and do not achieve it. That is the importance, because in this context with so much disability, this patient has got the right to be psychiatrically depressed. So what is the relevance of identifying that symptom? Because psychiatric depression can be corrected by counseling or drugs so that he will cooperate for treatment and try to improve the quality of life. Whereas if that mood disorder is part of the neurodegenerative disorder, the prognosis is not good. So it is important for us to differentiate whether it is a reactive depression or a dysexecutive symptom which is resulting in a low mood. So that we will analyze when we are getting more information. So apparently this patient has a choreic movement, young person, no tongue injury or
self-mutilation. Yes, ma'am.
Upper body onset, and now going into subcortical type of memory impairment. The first and foremost diagnosis is Huntington's disease.
Yes, ma'am.
Second will be having a Huntington's-like disease. Third, acquired causes are less important in this case. Very unlikely because symmetrical onset descending pattern.
Yes,
I will not think of NBIA and other things, even though they are all considered for differential diagnosis. They all have dystonia more than chorea, and these much more other parts of the neuraxis will be involved much more. Here it is a unique combination of chorea, cognition plus depression, organic or part of the neurodegenerative disorder. So first diagnosis Huntington's disease, second diagnosis Huntington's-like disease. All other differential diagnoses which we discussed can be put one after another low in the list, just for telling the number of differential diagnoses that you know to your examiner. Otherwise, it is Huntington's or Huntington's-like disease. Okay. You told that. Next is the speech. What is the slurring due to? Is it that we'll examine? He can have a lingual type of chorea.
Yes,
so that results in a,
because of involuntary movements only he's having.
That will ask when you analyze, we will say what it is.
Yes,
Then go to the past history. So the structures involved from the history are indirect pathway involvement, or you can call it as a caudate nucleus on both sides, plus subcortical type of cognitive impairment. Okay. Next.
Coming to the past history, patient is not a known case of hypertension, diabetic or thyroid disorders. Personal history is not contributory. In treatment history, patient has consulted in NIMHANS for the above symptoms in 2015, but reports are not available, and also has prescribed some medications, but there is no improvement, and patient has stopped all the medications since 4 years. Coming to the family history, in the family history, the patient's elder brother, patient's father, and patient's father's sister all had the same symptoms, and patient's father and patient's father's sister committed suicide, and the family history shows towards the autosomal dominant form of inheritance, ma'am.
Okay. Yes, ma'am. That is favoring our probable diagnosis.
Yes, ma'am. And coming to the summary, a young male patient with no comorbidities and no addictive habits, with chronic onset, gradually progressive involuntary movements, starting in the upper limb and then proceeding to the lower limb, also involving head, neck, and trunk, with behavioral changes, with no motor, sensory, cerebellar, or cranial or autonomic symptoms, with significant family history in the form of autosomal dominant inheritance, and it is affecting his daily physical activities. Coming to the differential diagnosis we have here are, it can be hereditary chorea, can be spinocerebellar ataxia, Friedreich ataxia, dentatorubrous pallidoleucine atrophy, Wilson's disease, and ataxia telangiectasia.
Yeah, now you know the history, no?
Yes,
chorea as the presentation, you can put hereditary chorea, Huntington's.
Yes,
second will be Huntington's-like disease. It is obviously Huntington's, I think. And first you will put Huntington's disease. Second, you can put Huntington's-like disease.
Yes,
then you can put chorea acanthocytosis. I will not put a spinocerebellar ataxia when there is no ataxia at all. I will not put a Friedreich's ataxia. And dystonia, nothing is there. Asymmetrical dystonia is dentatorubral pallidoleucine atrophy. You have no tremors and you have no asymmetrical dystonia. All those things are out. Wilson's disease, of course, any case we would like to entertain Wilson's disease because Wilson's can be a great imitator. So first will be Huntington's, next will be Huntington's-like disease, third will be chorea acanthocytosis, and fourth, for the feasibility of reversible condition, you can put Wilson's disease. Ataxia telangiectasia, there is no ataxia, there is no telangiectasia. So I will not consider that. So that will be my diagnostic order.
Okay.
Huntington's-like disease, chorea acanthocytosis, And with for the benefit of doubt, anything can be imitated, so you can put Wilson's.
Wilson's. Okay. Coming to the general physical examination, here is a young male patient, conscious, cooperative, oriented, moderately built and nourished, and vitals are stable. There is no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. Coming to the head-to-toe examination, there is forehead chorea present. There is increased frequency of blinking of the eyes.
What do you mean by forehead chorea?
When we ask the patient to see upwards, ma'am, there is also chorea movements in the forehead. Like
what is that called? That is called eyebrow lifting chorea.
Okay, ma'am.
You do like this.
Yes, ma'am, they'll do.
That is, I am not aware that it is called forehead chorea. Is it there in your book? They are called eyebrow lifting movements.
Okay, ma'am.
Eyebrow lifting chorea, they can be repetitive. Unlike general chorea movements are non-repetitive, eyebrow lifting chorea can be repetitive. So as far as I know, I am hearing this word for the first time. Eyebrow lifting chorea is very typical of Huntington's disease. So they frown like that. So that is the term used. If you have read it in some book, it is okay. But I have not read it because, as you know, medicine has got a lot of vocabulary. Many books might use many terms. But the term classically used is eyebrow lifting chorea. Okay. Next.
And there is increased frequency of blinking of the eyes.
Okay.
And there is a tongue chorea, that is jack-in-the-box tongue or the lizard tongue.
Okay.
Then there is pronator swing.
Okay.
Then piano playing sign, that when we ask the patient to stretch the upper limbs, there is movement of the fingers, ma'am.
Okay.
This is the tongue chorea, that jack in the box. Tongue.
Okay. Okay, ma'am.
Yes, ma'am. These are the choreograph movements, ma'am.
Okay.
And this is the piano sign, playing sign, ma'am. When we ask the patient to stretch the upper limb, there will be movement of the fingers.
Okay.
Coming to the CNS examination, the higher mental function examination. The MMS scoring for this patient, it came 20 by 30, ma'am. There is orientation to the time and place is present, normal, but there is impairment in attention, calculation, recall, and reading, writing, and copying also, ma'am.
Okay.
So it suggests mild cognitive impairment.
Yes.
And speech, the dysarthria is present, and it is mainly labial and lingual, ma'am.
Okay.
Lingual type and labial type of dysarthria. Then coming to the motor examination, attitude, the patient is sitting on the bed with legs hanging down, with the hands kept on the thigh. The bulk in the arm, it is 26 centimeter both side, forearm 23 centimeter both side, thigh 40 centimeter both side, and calf 33 centimeter. Tone, hypotonia is present both in the upper limbs and lower limbs, ma'am.
Yeah.
And power, it is 5 by 5 in both upper limbs and lower limbs. Coming to the reflexes, the corneal and conjunctival reflexes are intact. The plantar reflexes couldn't be elicited because of the involuntary movement. And deep tendon reflexes, the biceps jerk, triceps supinator, knee and ankle jerk, all are 3+. And there is no clonus. Coming to the involuntary movements observed, the involuntary movement observed can be described as quasi-purposive. They are non-rhythmic and non-repetitive, non-patterned. They're of large amplitude and multidirectional. They're crossing the large joints. And coming to the gait of the patient,
better not to use that word non-patterned.
Okay, ma'am.
You call it as a non-patterned.
Yes,
when you have got a movement disorder which doesn't fit into the recognized movement disorders. So this fits into a choreic movement. No, usually an unpatterned is used to describe psychogenic movement disorder.
Yes, ma'am. Yes, ma'am.
So I think what you mean is it is not repetitive and going on changing. Maybe that is what is in your mind.
Yes,
but this term is generally used for non-organic, where you don't fit it into a pattern of hyper or hypo.
Okay.
So that you will not use. That term you will remove. Okay.
Then coming to the gait of the patient is impaired. There is increased variability in the step and stride length, and also increased stance and decreased swing phase. This is the gait of the patient, no?
Okay.
Coming to the cerebellar and primitive reflexes are present. Glabular tap and palmomental reflexes are present, ma'am. And cerebellar signs couldn't be elicited because of the involuntary movement. And sensory and autonomic examination is normal, and other system examination is normal. Coming to the diagnosis, the neurodeficit here is coriform movements. The anatomical localization we can make to the caudate nucleus. Pathology is degenerative, and etiology is hereditary. From this, after examination, we concluded to come to the differential diagnosis of it can be Huntington's disease or Huntington's disease like or
When
neuroacanthocytosis.
you put anatomy, caudate nucleus, what is left out now? The memory and the behavior.
Behavior and problem.
So, of course, one of the structure involved is definitely caudate nucleus, but it
Yes,
is
ma'am.
more than caudate nucleus. So, what would you like to say? You can call it as an indirect pathway. In the
Yes.
indirect pathway, you have got cortico, striato, pallido, thalamocortical. So, cortex gets involved in that circuit. So,
Okay.
instead of caudate is definitely involved. But
Yes, ma'am.
now, as the disease progresses, he has developed neurobehavioral and cognitive features that cannot be explained by a pure caudate lesion.
Yes, ma'am.
So, better you can put it as an indirect pathway, or you
Indirect
can
pathway.
put the caudate with the frontal subcortical circuits, like that.
Okay.
It looks like a subcortical dementia. We decided, no, it is mental slowing.
Yes, ma'am.
You call it as a caudate nucleus with subcortical circuits. If you want, you can tell like that. Or you can call it as an indirect pathway. Cortico, striato, pallido, thalamocortical is the direct pathway, which when involved, it will produce the slowness. Cortico, striato, pallido, subthalamo. This subthalamic nucleus is introduced after the cortico, striato, pallido.
Okay, ma'am.
Then subthalamo, then thalamocortical. That is indirect pathway. Subthalamic nucleus is introduced after the cortico, striato, pallido is indirect pathway. Direct pathway is cortico, striato, pallido, thalamocortical circuit. Cortico, striato, pallido, subthalamo, thalamocortical circuit is the indirect pathway. You have got a hyperdirect pathway, that is cortico, subthalamocortical. That is the one which produces hemibalismus.
Hemibalismus.
Then you have got striatonigral, nigrostriatal. That's a classical Parkinsonism and Parkinsonism plus syndrome.
Yes,
Then you have got a striatum to pyramidopondine oscillator complex. So that is typically involved in PSP syndrome, where they get the oscillator complex impairment resulting in frequent falls.
Yes, ma'am.
So these are the 5 major circuits of which you can put it in the indirect pathway. Okay.
Yes, ma'am.
Any investigations done?
Ma'am, MRI brain of the patient has been done, ma'am.
What does it say here?
No, ma'am, it has suggest mild diffuse cerebral atrophy, ma'am.
Did they look at the bicaudate, caudate? The film is there, huh?
Film is not there.
Generally, we look at the frontal horn where the caudate becomes atrophic.
Yes,
So
ma'am.
there will be a waist-like middle constriction, and the posterior part of the atrophic caudate produces dilatation that results in a butterfly-like appearance of the frontal horn.
Yes, ma'am.
Then you have got the bicaudate to biparietal distance ratio.
Yes, ma'am.
Because of the caudate atrophy, bicaudate distance widens and the ratio becomes altered. Diffuse atrophy can be there, but most important is caudate atrophy, resulting in altered frontal horns, and the ratio between the bicaudate to the biparietal becomes altered.
Yes,
Okay. So that is film is not there.
it is not there now.
Okay. Anything else? Did they do the genetics? It's a trinucleotide expansion disorder. If that is demonstrated, it becomes Huntington's. If it is not demonstrable, it becomes like disease. And if you see peripheral acanthocytes, it goes into acanthocytosis.
Yes,
So what is the importance of knowing this genotype? like his father, if this person marries, if you know his exact phenotype, you can do the prenatal screening and detect whether it is there. That is the most important thing. Otherwise, we are not going to do much to the gene therapy level at this point of time.
Yes, ma'am.
Then what else you are going to do for these patients? So MRI will be useful. Genetic can be done.
Yes, ma'am.
And so third important thing is treat the symptom and counsel him. His family members have had neuropsychiatric symptom and committed suicide.
Yes, ma'am.
So he will need counseling to prevent such devastating complications. No?
Yes,
And
ma'am.
how are you going to control the involuntary movement?
We can give dopamine receptor blockers, like atypical antipsychotics and typical antipsychotics.
So better to avoid them. Why? Because this patient will need very long-term treatment.
Yes, ma'am.
And already he has got the indirect pathway involvement. So when you put him on antipsychotics for long term, he will go into classical Parkinsonian features. So in addition to chorea, he'll get Parkinson's. So better in long term, short term you can use it. In long term,
vesicular monoaminotransferase inhibitors.
So yeah, what we are commonly used is carbamazepine. It's a membrane stabilizing agent. So carbamazepine is the ideal drug to stabilize the involuntary movement. Sometimes high dose INH is used. Supposing short term, tetrabenazine, antipsychotics, all of them are not used for long term. Tetrabenazine is having low profile, low potential, unlike antipsychotics, but still for long term use, it is not safe. Tetrabenazine is ideal for chorea, for tics, rheumatic chorea.
Okay, ma'am.
It's a short-term disease.
Okay,
or you have tics. So those things you can treat with tetrabenazine. Otherwise, the drug used is carbamazepine. Sometimes you can use INH. Major antipsychotics, minor antipsychotics, atypical antipsychotics, or tetrabenazine not used. You can use them for 1 day or 2 day briefly so that the patient gets convinced that you can offer him something and waits for the results of carbamazepine. That way, if you want, you can use, but long term, you should not use. So that is the movement control. He can do cognitive training. He's only having mental slowing. So he can be going to cognitive training so that cognitive, the disability adjusted life years, no? DALI can be prolonged by doing cognitive training. His cognitive capacity deterioration can be prolonged. So that is the second thing you can do. And you have memantine, subcortical dementia, memantine can be used. But it doesn't help much, but these are the options. Carbamazepine will, in some patients, control the involuntary movement very much. Or you can use INH. And you should not use atypical or typical antipsychotic except for few days. And cognitive enhancement therapy and psychological counseling to prevent suicide or homicide or violence can happen.
Yes, ma'am. Ma'am, I have a doubt. Does tetrabenazine worsen suicidal ideation in Huntington?
Tetrabenazine, I am not knowing that it will produce suicidal ideation, but tetrabenazine is not good. Yes, even though it is milder than major and atypical antipsychotics, it will also produce Parkinson's. Only for a short period you can use. Suicidal ideation is part of Huntington's disease.
Yes, ma'am.
It is one of the neuropsychiatric manifestations of Huntington's disease. But if you think I don't know, whether I don't know what to tell you. Yes, we don't have much to offer to them. And how long you will tell them to hold on to that havoc of living with the cognitive impairment, neuropsychiatric complications, loss of quality in life. All this, how long you can hold on, I don't know. But life has to be sustained. That is our duty and responsibility. So we'll try to counsel him, Purva Janma Karmas, and like that, and tell them to understand and go through the agony. So this is, I think, Huntington's disease. Looks like a typical. I would, if I had seen the MRI, I would have known, because you see, when just without telling the history, you give it to the radiologist. They'll just look for infarct tumors, gross changes. They may not do the finer qualitative analysis. So that may miss many of the things. I am sure he will have bicardic retinopathy.
Yes, ma'am.
Anything else, ma'am?
Nothing, ma'am.
He is not yet married, better not tell him not to marry.
Yes, ma'am. They were asking the same, ma'am. Like,
He's 37, he is disabled, he is dependent, and
yes,
he has got a genetic disease.
yes, ma'am.
So you should explain all those things to them.
Yes, ma'am.
It is a Huntington disease. Anything else, ma'am?
Ma'am, you had once shared in the classes about one case that you had seen, VGKC encephalitis. Like,
Faciobrachial dystonia usually produced, this is not like a symmetrical distal classical chorea with the subcortical dementia. I think maybe you are telling about that best teacher awardee teacher. Is that what you are telling?
yes, ma'am. Yes.
She had a faciobrachial dystonia.
Okay.
She had the classical triad of panic, sleepiness, and involuntary movement. The panic was mistaken as menopausal syndrome. Sleepiness was attributed to drug, and the faciobrachial dystonia was attributed to antipsychotic. So the whole diagnosis is missed. So it is a triad, which I myself found out, clinical triad. Because many times they land with the, now everybody has become oriented and over-diagnosing autoimmune disorders because there is a seronegative advantage is given to us. Everybody will label it as seronegative. That and give them immunoglobulin and everything, and looking for an answer even in degenerative situations. But those times, the earlier times, every case was missed and pushed to the psychiatrist. So that time I analyzed a group of patients and found that panic, new onset panic, sleepiness, and involuntary movement, any one of them, or catatonia. That is the triad. It is now called Chandra's triad. That is the clue for autoimmune. So this is chorea. It can happen, especially in children. Chorea can happen in NMDA. Otherwise, this kind of chorea is not common.
Like, after that, just when that paper was published now, like the triad after your name, just 1 week after that, we had seen on NMDA encephalitis exactly like everything was fitting.
It is there because I have seen those days, earlier days when the awareness was little less. Many of them landed with the psychiatrist. Some of them received even ECTs. And a treatable disease should not become. So I collected a case and analyzed the common symptoms. And like that, I got that right. So that is good, no?
Yes,
very useful.
Any other question?
Nothing. One more, this depending on the number of the repeats, like the disease
That is called genetic anticipation. All trinucleotide repeat expansion disorders, the expansion increases with subsequent generation. That is a mechanism of natural selection. You see, supposing the father got it 60, son gets 37, now his son will get it at 25. And his son will get it at 15, so they never get married and the disease becomes eliminated. So, trinucleotide repeat expansion is nature's method to eliminate the weak.
Yes, ma'am. If repeats are more, the disease will be juvenile onset and it will be called Westphal variant, no, ma'am. Have you seen any case?
Yes, I have seen, ma'am. Westphal variants have more rigidity, more dementia, and less chorea.
Yes, ma'am, less chorea.
Any other question?
No other questions.
It's a straightforward case, but you presented very well, ma'am. Good.
Thank you, ma'am.
Thank you.
Thank you so much, ma'am. Thank you so much for teaching us all this.
Thank you very much.
Thank you.
Thank you, ma'am.